Okay, let's look at the last block that we have for the basics in pharmacology. And what we'll try to do is work with some in-time class time to actually apply some of these principles in practice. What we'll look at here is to look at developing a collaborative practice with a multidisciplinary team to provide really in developing an optimal, safe, effective, evidence-based, and patient-centered plan of care using drug therapy. So there are really four principles that I encourage you to think about that should be elements of your plan of care for a patient when you develop one. And in practice, these are principles that may or may not be organized in this very way, but these are the thought processes that should go through your mind when you're developing or approaching treating a problem. So you basically you look at everything you've got about the patient and you come up with their problem list and you prioritize their primary problem is often related to what their chief complaint is, but typically their primary first problem is the most critically important acute problem they have that they came in for today, or that in your assessment is their biggest problem. And then you'll have maybe a second, a third, a fourth, a fifth problem. Under each of these problems, you should have a diagnostic plan, a therapeutic plan, a monitoring plan, and education plan. Even if it's not specifically organized in this way, every problem deserves a plan of approach of care that's organized and thorough. So the first thing that we'll look at in their first problem is to look at diagnostically, what do you know and what do you need to know? So things on this diagnostic plan would include what the allergy history is, what the current meds are, what the patient's wishes are, what their prior assessments are, what labs they've got, what you found on physical diagnosis. And then based on your working diagnosis or how confirmed you are with what their problem really is, what future things do you need? So, for example, you're not quite clear based on what they told you for their meds, so you need to get a more thorough med history. You have already gotten their baseline vitals, but you need maybe vitals one more time because what you got for vitals coming out in the ambulance may or may not be accurate. You need a certain set of lab tests done. You might need to get a metabolic panel. You might need to get their red blood cell count. You might need to get certain lab markers of certain inflammatory states or diseases. For example, if you're ruling out an MI, you want to get troponins as well as an EKG and sort of other things that you need to get. So the diagnostic plan is based on your first problem. What do you have and what more do you need? Next is the therapeutic plan. Here what you're looking at is to say, okay, how are we going to manage this problem with both drugs and non-drug intervention? So maybe the issue is diet and exercise, lifestyle changes, stop smoking, but then the drug therapies might include somebody's coming in with chest pain, then you're going to look at giving them morphine, oxygen, a beta blocker, aspirin therapy, and you're going to have definitively what doses we're going to give and what routes of administration. You've evaluated what meds are already on board. You make an assessment for what drug interactions are there and what you need to manage or monitor for. You should also have for everything that you include, both drug and not drug, there should be a clear evidence that supports that rationale. So some of those protocols are protocol driven from practice guidelines that your institution normally uses. So every patient who comes in with this problem, these are the standard battery of tests we do diagnostically. Here are the standard therapeutic approaches we use, but you have to apply to the patient you have in front of you. So there might be, for example, a reason why this therapy, while we give it to 90% of patients, we're not giving it to this patient because of their allergies, their concurrent drugs, their something else. The third is their monitoring plan, that once you've got their drugs and non-drug approach and plan, then what are you going to do to monitor that the drugs are working? So how do you know the patient's getting better or at least they're stable? Also, what do you monitor for adverse effects? Do you need to get electrolytes? Do you need to get other lab values, and when do you need to get them? And finally, your education plan. What do you share with the patient? How do you work with the patient to tell them, okay, here's what we found, here's what we're going to be doing, these are the drugs we're going to do, these are the non-drug things we want you to take part in and get involved in. You're going to need follow-up to see me in clinic in next week, whatever the education plan is. So really, for every single problem, you need to have a clear diagnostic plan, what you've got, what more you need diagnostically, a therapeutic plan, what you're giving as intervention, both drug and non-drug, a monitoring plan, what kind of issues come, do you need to monitor for, what, vital signs, how often, lab tests, which ones, how often, when are you going to get them, when are they coming back to clinic, when do they need another physical assessment, the like. And their education plan that is simple enough for patients to understand. So you really want the education plan to be in common language the patient understands based on their education level and as simple as you can make it. Ideally, you don't want to include more than 3 important key points because people won't remember that, and you want to incorporate, when it's appropriate, family members or someone else and maybe written material to help support and retain that education plan that you've got. So keep in mind that all of this is a model for thinking, that in practice you may see all of this digested in a more simple note. You could well imagine that the first time you have to come up with a pharmacotherapy plan for a patient, it may take you hours to do one and you get quite frustrated. And the next time you do it, it may take you only 3 hours. And the third time you do it, it may take you 2.5 hours. And the next time, 2 hours. By the time you get done and you're in practice, this process of developing a pharmacotherapy plan for each problem happens in 10 or 15 seconds. It happens quite quickly. It's integrated in your thinking. So keep in mind, as frustrating as this might feel at the moment, it's like learning a brand new language. It's like learning a whole new culture. And of course, you have to be patient with yourself, but to recognize that all of the ways we think and approach this all happen quite in a quite integrated kind of way. There are ways to kind of think about finding the ideal pharmacotherapeutic plan, and what you might want to consider, and what we're going to have you do on the monographs, or having you do on the monographs, revolves around looking at what are the best agents for other comorbidities. So is that agent based on those other patients' comorbidities? Is this an ideal agent to use? Meaning we're doing double duty. This is a great drug if you have both hypertension and diabetes. So let's say you have someone who has hypertension and they have diabetes. The first problem they're coming in today for is their hypertension because their blood pressure is a little up and it's been up for a little while. And so you're looking at all the drugs you can choose for that you could use, and you pick lisinopril, an ACE inhibitor. Well, the issues are with an ACE inhibitor is that it actually is very beneficial also for patients who have heart failure and patients who have diabetes, that it will improve outcomes for reduced renal problems in diabetics, and it improves life expectancy in heart failure. So if someone happens to have heart failure and or diabetes, their first go-to drug is going to be a drug like lisinopril, unless there is some other problem associated with it. So you go down the list, maybe the patient doesn't have any of these problems except that this patient is a woman of childbearing age and she could be pregnant. And so all of a sudden, while lisinopril is a great drug to use for her hypertension and her heart failure and her diabetes, if she is of childbearing age, then you need to make sure she either doesn't get pregnant because these can cause fetal malformations, or you have to go to a different drug. So what we'd encourage you to do is, as you work through your thinking about these, keep in mind that what is first-line therapy for many patients may not be first-line based on a comorbidity or an allergy that the patient has. It's also important for you to look at running a drug interaction check as you're adding or subtracting drugs from your therapeutic list. There are many applications that can do this in the healthcare systems. Most hospitals have or healthcare systems have for you access to different software. Here's an example of Lexicomp software for drug interaction checking. And you just pretty much add drugs and they'll tell you what the interactions are specific to the list of drugs you import into that. In addition, if you're working in an electronic medical record, many times, but not always, the electronic record will flag when you've added a drug that potentially interacts with drugs the patient's already receiving. So just recognize that you'll need support, electronic support in evaluating drug interactions. So some of the basic principles of therapy we think of when you're developing a therapeutic plan for patients are to be able to list and prioritize what the problems are. To be clear, you understand what the patient's goals are. So the patient may have goals about trying to keep things simple. They may want to eventually decide, hey, if this continues in this rate, I want to go on hospice or palliative care. Or the most important thing for me is that I can go to my granddaughter's wedding in 2 months. So work on setting treatment goals, but being clear with the patient that that's aligned with the patient's goals, and then being clear that there's a clear indication for every drug we're using. Making sure you have adequate baseline information for patients, particularly in older patients. We might want to get orthostatic blood pressures, get their falls history, look at their cognitive function, look at their bowel and urine function, and then we have a baseline. Then when we add something, we can compare it to how they were before we added it and determine whether or not that drug is causing a potential problem. We also want to make sure we have baseline data of weight, height, serum creatinine, creatinine clearance, albumin. We want to make sure, particularly in older folks, if they have a risk for falls, we've done some kind of a falls assessment. We need to be clear we're evaluating the risk and benefit of each drug and minimize polypharmacy or combinations of drugs when a single drug will do. So polypharmacy is when we're using more drugs than we need. Sometimes we add on drugs to treat side effects of other drugs. That's really a big no-no. Whenever you can avoid that, we do. You want to look at the streamlined dosing, and once-a-day regimens are always preferred because people adhere to them better than twice-a-day or 3 or 4 time-a-day regimens. You want to evaluate and manage their interactions and keep your communication open with the person you're working with, particularly the older folks, and their whole support network and family. Whenever it's possible, work to simplify regimens. That's not always easy to do, but you do the very best you can. Also recognize that patients may have some issues with adherence. They often have some unresolved concern. They haven't communicated with you. They misunderstood what was going on, or the regimen is just too complex for them to work through. Be aware of their patients' literacy and their health literacy. Many, probably maybe a third of patients that you'll work with in practice, surprisingly don't understand how their bodies work. So when they get newly diagnosed with diabetes and they have to start doing finger sticks for blood sugars, when you have to eventually add on insulin and they have to count their carbohydrates and read nutrition labels, and it's overwhelming for patients, and particularly if they're having difficulty with math skills or understanding basically how their body works. And so important to look at what those barriers are and provide the support and education they need so that they're in a better position to meet with success for the intervention you've got. If patients don't have their concerns resolved, if they're not on board with you on what you're doing, they typically won't get their prescriptions filled, or they won't fill them correctly, or they'll take the dosing of the medication in a way you didn't intend it to happen. Finally, the way to simplify regimens that is really difficult to do, because more difficult than it would seem, is you want to eliminate pharmacologic duplication when it's ever possible to do that. You want to look at decreasing the dosing frequency to once a day, and you want to periodically look at the regimen and ask, is the patient still taking it? They still need it? Is there some regimen issue that could be simplified? Have patients bring everything they take in with you, brown bag, meaning their meds, their prescription meds, their non-prescription meds, their herbal supplements, everything, their probiotics, all of it, and make sure that you have access to all of that and look it through. Okay, very good.